Just a reminder about next week's speaker. We will be hearing from Dr. Sam Saha from OHSU. He'll be discussing racial and ethnic disparities in healthcare. Today, we are very excited to have back with us our own Dr. Bob Gluckman. As many of you know, he is the Chief Medical Officer for Providence Health Plans. And Dr. Gluckman brings to this position really a wealth of passion and clinical experience, much of it spent here at St. Vincent's, where he was previously the medical director of our clinic, as well as then Chief Medical Officer for all of the teaching clinics for Providence Medical Group. Dr. Gluckman earned his medical degree from Pritzker Medical School, University of Chicago, and then did residency in internal medicine at Michael Reese Hospital in Chicago. He's well known for his leadership positions and advocacy, particularly within the American College of Physicians, where he previously was honored with the Distinguished Service Award at the national level, as well as the Laureate Award for the Oregon chapter recently in 2013. Dr. Gluckman is a voracious reader of the medical literature, keeping up on evidence, and really makes him well-suited to give talks such as those today, updating all of us on the latest in internal medicine. Thanks, Dr. Gluckman.
Thanks, Laura. You know, I see Pat Goodall in the back, and I went to talk to him before, and he said, "How can you still give this talk when you haven't touched a warm body in 5 years?" And you know, so you know, Pat, for the residents who don't know, he was a very elite infectious disease doctor here, and he humbled me then. He'll humble me now. But I did tell him, you know, one of the advantages I now have is I get to actually look at data for, you know, over 500,000 people and think about practice patterns and get to see what are our gaps and how can we maybe do some things differently or better. And I'm really grateful for the opportunity to get a chance to come back. I see people, I go up to the clinic once a month and precept residents still, but you know, I'm grateful for the opportunity to share my thoughts for you, with you today. So I do have some healthcare stocks where there's that I'm disclosing for conflict of interest purposes. I will highlight that one of the papers that I'm talking about today has to do with anticoagulant agents, and I believe that Bristol-Myers Squibb makes one of those agents, although I'm not discussing any agent in particular. I would just kind of highlight that that's one potential conflict of interest. I don't think anything else I'm talking about today is particularly relevant, but I wanted to make sure those disclosures were there. So, as you know, when I do this, we have a kind of a long list of topics, and we try to see how much we can get through in an hour or so. But I'm going to talk a little bit about breast cancer screening, have a paper to share about patients who have low-risk DCIS, because I want that to kind of be a springboard about thinking about what do we do with screening results in certain populations. As you know, there's a landmark paper this year that makes us rethink how we are going to treat hypertension, and coupled with that, then a paper on what medications we may use when a patient appears to have resistant hypertension. And then a pretty big theme today is this idea of personalized treatment of chronic disease. And I'll give some papers and some clinical examples around that. We hear a lot about personalized disease treatments in oncology, but I think it's coming up for, you know, it's always been something that we do. It's getting more and more important that we do that, and it's getting to be a little bit harder about thinking about how do we apply guidelines in the literature to the patient that we see in front of us, while we also have systems in place to identify gaps in care and opportunities, and recognize that when someone is highlighted on one of those gaps on a performance measure, it doesn't mean that you did something wrong. It means that it's you know, a potential for an opportunity, and that's why those targets are not 100%. We have to really be thinking about that and not be offended when someone pops up on our list, because you may be doing the right thing, or there may be an opportunity. I'm going to talk a little bit about restarting anticoagulants after GI bleeding and atrial fibrillation. I'm showing that because the health plan had a 30% increase in stroke this year, and it looks like half the patients who have had a previous diagnosis of atrial fibrillation are not on anticoagulants. So that's something that we can certainly be doing something about. A few thoughts on new treatments of hyperlipidemia, statin resistance, and spinal stenosis, spinal injections if we get to it. So you know, the big news in breast cancer screening this year is that there are two revisited guidelines that were published. One is the American Cancer Society's breast cancer screening guideline in JAMA in the fall, and then the USPTF revisions just came out. And so they don't exactly say the same thing, but they're a lot closer than they used to be. So let's take a look a little bit about what those differences are and why they are there. So the first thing is that the recommendations are limited to women who are at average risk for breast cancer. So the first thing to do is actually assess someone's personal risk to see if the guidelines even apply to them or not. And so it's not that hard to assess the risk. It's basically their past medical history and family history using a risk tool. I don't know if EPIC has an embedded risk tool in it. There are some quick questionnaires that could be done at the time of a visit that you could check somebody off. I'm going to show you a copy of Group Health's old one that is a little bit dated because the recommendations are tied to the old recommendations about screening, but the questions are still the same questions. So I think getting a risk tool in place to say, does a guideline and this shared decision-making approach even apply to the patient who's in front of me? They performed a systematic evidence review and graded the evidence. That's actually different for the American Cancer Society compared to how they've done guidelines in the past. So this is a little bit more in keeping with the USPTF's approach. And then they made recommendations instead of the grade A, B, and C, D and I that we see in the USPTF. They made a strong recommendation, which was basically defined as most individuals would want the recommended course of action, and most providers should really recommend this, and that the strong recommendation would be appropriate for a performance measure. And then they made what they called a qualified recommendation, was that in their opinion, the majority of individuals would want the recommendation, but not so many that it should be done routinely, that it really warrants shared decision-making. And that from a physician perspective, they should be identifying what's important to their patients. And those criteria, the differences there, would not be appropriate for a performance measure. This is the kind of questionnaire I just kind of, gave as an example, but there's a section here for personal history about whether they had a breast biopsy or radiation therapy or previous breast cancer or ovarian cancer. Then there's a section around family history, which looks at their mother's, first-degree relatives, mother, sister, daughter, and then an extended family history, focusing on the previous histories of breast cancer, ovarian cancer, or whether any men in their family had breast cancer. So it's a pretty quick questionnaire, and if any of the boxes are checked, then they're a higher risk person. Should kind of be done somewhere routinely in our wellness visits. Doesn't have to be done, necessarily every year, I don't think, but has to be done somewhat frequently. So basically the skinny here is, what did they recommend? And they recommended that screening start at age 45 and continue as long as overall health is good and life expectancy is 10 years or greater. And that was a strong recommendation. So that's what they think is appropriate for a performance measure. Performance measure today is the USPTF, starts at age 50, extends to age 74. So it's a lot closer than it used to be, when it was 40. And then the other issue is about the frequency of screening, and those are all qualified recommendations. So the USPTF, it's shared decision-making before age 50, and it's every other year from 50 to 74. ACS guideline says we think that women between the ages of 45 and 54 should be screened annually, and at age 55, they could be transitioned to every other year screening. They think that women should have the opportunity to start screening at age 40 so that, as a marker that, payment or reimbursement for those services shouldn't be denied. People should have the opportunity to think about whether they want this or not. And that they should have the opportunity to undergo annual screening so that there shouldn't be payment differentials based on that. But, when we have systems in place for recalls and encouraging people, I think that it does make a shift to say, does the patient need to get a letter every year that says this is time for your mammogram? And I think that's a discussion that's going to have to occur with the radiology departments now, because now we have consistency among guidelines on the two major recommendations that every other year screening at age 55 is appropriate. And then clinical breast exam is no longer recommended. So I don't know, back in the day we used to put a lot of effort into training people on how to do a clinical breast exam, and I'm sure that there's plenty of things in the curriculum that can replace that. So the USPTF, just published online 3 weeks ago. It basically didn't have any major changes to the previous recommendations. Continues to recommend every other year screening for women age 50 to 74. Gives a grade C recommendation, which essentially means shared decision making. It doesn't mean don't do it for women before the age of 50. with the caveat that if a woman places more emphasis on the benefits of screening over the potential harms, such as callbacks, unnecessary biopsies, and the potential for overdiagnosis, then they may want to delay screening to 50. And to give some perspective in the evidence review, the mortality benefit for screening women under the age of 50 is 3 lives saved for every 10,000 women screened. And it's quite a bit more than that in women 50 and over. So it's not like it's 0, but it is less beneficial. And then the other issue that came up, which got a grade I recommendation, is what to do with women 75 and over. It said there's insufficient evidence. The ACS says if somebody has a good life expectancy, more than 10 years, that they should be screened. And they take no position on the use of tomosynthesis as a primary screening method, or the use of ultrasound or MRI for women with dense breasts in an otherwise negative exam. I think last year or the year before I presented a paper here that looked at the cost implications of routine ultrasound screening in average risk women after dense breasts, and it was well over $500,000 per quality adjusted life year. And I emphasize again, that's for average risk women. So, women who are at higher risk need maybe more, but women who are not. And so that would be a practice that we should probably be discouraging. So what are the areas of controversy, and why do they exist? Well, the one was the age to start screening. So USPTF says 50, ACS says think about it at 45. What was their rationale for doing that? So what they did was they looked at the risk of developing breast cancer over a 5-year period by these brackets and said, well, it looks like the incidence of developing breast cancer between 45 and 49 is similar to the incidence between 50 and 54. So waiting to age 50 seems to be kind of arbitrary. Whereas the incidence of developing breast cancer between 40 and 44 is, about half that between 50 and 54. So there's a rational basis to saying, as women are older in their 40s, that maybe because their risk profile changes, that you can start screening then, and give a sense that the value in women that closer to the age of 40 is less. Their other thing was that they noticed that the deaths by age at the diagnosis for women between 45 and 49 were also very similar. Actually, this is a typo that I forgot to switch. This is 11%. So they're actually very similar. It's the prevalence or the development of breast cancer diagnosis that is this 10 versus 12%. And so, it's also much narrower. And so that was the impetus for the ACS to say, maybe we should. It's perfectly reasonable to start a little bit earlier. Their rationale for continuing screening for women who are otherwise in good health is that the incidence of breast cancer increases to age 79, and over a quarter of the deaths occur after age 74. But they do make the caveat and note that there's no benefit for screening women in poor health as defined by a Charlson Comorbidity Index of 2 or greater. And these are things that we've talked about before, that actually so many, it's still the minority, but it's a significant minority of women who get mammographic screening as they're elderly are fitting into this poor prognosis group. And for them, we're doing more harm than good. So I'm going to show you again some tools that you could use to help assess prognosis that I think should be part of our routine adult wellness visit programs in the Medicare population. I've shown them here before, and I think I'll try to show them again, and hopefully people do them all the time on people where they're thinking, well, what is their prognosis? The other big controversy was whether women should be screened every other year or every year. So what was the basis for that? And the basis for that was for premenopausal women who have every other year mammography, they have a 28% increase in advanced stage cancer compared with the shorter screening intervals. Now, this may not translate into a mortality benefit, but it does probably translate into a less aggressive required treatment for the patient. So less likely to have a total mastectomy, less likely to have chemotherapy. And because of advances of treatment, some of the mortality benefits may have narrowed. But that is the rationale for the recommendation to screen annually until age 50, through age 54, because most women will have gone through menopause at that time. But they also note that the tumor characteristics were similar in women over the age of 50 who undergo annual versus biennial screening, which really does kind of point to the fact that, as women are over 50, every other year screening should be fine because we're cutting out the number of false positives and recalls by over 30%. And so, the idea, I think, today that the annual mammogram for women in their 60s is probably not appropriate because there's no proven benefit and there's proven harm. And, I think that it's probably time to get our radiology departments to start to do their letters. My vote would be 21 months because then you got plenty of time to get people in for 24 months. And in your conversations with people, if they're older, you could probably, feel very good about shifting to biennial. This is kind of a nice schematic from the JAMA paper that basically shows what the differences are. It's kind of all the things that we've discussed. Option to begin screening, do not screen. They recommend screening annually. Here's screening every other year. They recommend transition to screening every other year for 2 years. The option to screen annually, I think that, this is where, you can't necessarily tell people, no, you can't have this, so there's not going to be payment policies against this. But if we go through a shared decision-making policy, or if we invest the time and energy for active recall rather than passive engagement with patients, but when we're really pushing this to get done every other year seems to be appropriate. And then, this issue of the elderly, I think actually doing an active assessment of people's life expectancy and prognosis and thinking about them as individuals is pretty important. And I'm going to show you that in a second. I thought this was also an interesting paper. It was from JAMA Surgery this year. It's looking at the survival benefits for treatment for low-grade ductal carcinoma in situ, and it's a retrospective cohort study. I basically kind of want to show this because what happens in this country when someone gets cancer is it's very difficult to have the conversation with them that says, well, it's not really that bad of a cancer. We shouldn't even call it cancer. And we should just live with it, and you should really just ignore it. And the patient's thinking in their head, I got cancer, I got cancer, I got cancer. And so we have to arm them with information because that's harmful to people. So here's this cohort, over 57,000 cases. Not a lot were treated without surgery, 2%. Out of the DCIS cases, but 2% of 57,000 is still a big number. It's not like you can't get any information out of that number. And about 20% of those DCIS patients were grade 1 or low grade. And here's the survival impact of treatment with surgery versus no surgery. Low grade ductal carcinoma in situ, no surgery, 10-year survival 98.8%, surgery 98.6%. There is a modest benefit if you have high-grade ductal carcinoma in situ, but if you're 85 years old, and you have some comorbidities, I don't think that's and somehow the mammogram got done, we could do a little less harm here. And for this population, this is avant-garde, but I got a hard time saying what we should be doing for a 75-year-old that says they should be having surgery instead. They may need continued mammography to make sure they don't get invasive breast cancer. But I think there's ways to reassure people. So I think low-grade ductal carcinoma in situ, 10 years. I don't know about 20 years or 30 years. But if this comes up, I think you can reassure people that their prognosis is quite excellent. And these are the websites that you can, at the bedside, do a prognosis calculation for someone. This is something a medical assistant could probably do, especially this top one here. I think at the time you're doing a wellness visit, and sometimes you can do the eyeball test. The person's playing tennis, they got no medical problems. Okay, I get it. But as you move into more disease states, a little evidence of frailty, do a functional assessment. They don't walk so well, need some help with activities of daily living. This is the time to do these things and maybe stop doing things to patients who have more limited life expectancy. So I'm going to move to hypertension and talk about the SPRINT trial, which was published in November in the New England Journal of Medicine, which I think is probably the most important paper in my mind that was published this year. And kind of groundbreaking about what we're going to have to do to think about hypertension, and it makes it a little bit more complicated. So almost 10,000 patients, and the eligibility criteria were that patients had a systolic blood pressure of between 130 and 180, and they had to be at high risk for cardiovascular disease. And they defined that as patients who either had clinical evidence of cardiovascular disease other than a stroke. They excluded strokes for reasons unclear to me. They could have chronic kidney disease, except polycystic kidney disease, and they had to have an estimated GFR between 20 and 59. So some of those people are sick. Most of them are sick. they had to have a Framingham 10-year risk score of greater than or equal to 15%. This was the actual reason that most of the people were in the trial. 61% of the patients had a Framingham risk score of 15% or greater. They could be anybody older or equal to the age of 75. And that was about a quarter of the population. So it includes older people. And then we're going to get into that a little bit later because I'm going to be like a pendulum swinging back and forth. Treat aggressively, don't treat aggressively, treat aggressively, don't treat aggressively, just to confuse you. And then it is important to kind of recognize that they excluded these this is CVA, diabetes, CVA, symptomatic heart failure, end-stage renal disease, and they also excluded people who they didn't think could adhere to a treatment, which is, half the people. So, but so there's a little bias there, so, that you have to kind of deal with. But I think it still says something about, what you can do if you have programs in place to try to promote adherence. And, they had to stop the trial early due to the significant benefit, and so the trial only lasted 3 years. They randomized people to a treatment target of 120 systolic versus 140 systolic. And they used a treatment algorithm that was similar to the Accord trial, which was done on diabetics, which was reported not to have a positive result. That's one of the areas of controversy. But pretty straightforward. The top 3 drugs for hypertension, diuretics, an ACE or ARB, or calcium channel blocker. That's JNC8. Many patients require 3 drugs. These should be the first 3 drugs that you think of when you're looking at a patient with hypertension and they're not controlled. Are they on these 3 meds? If they're not, why not? Because they should be. And then they allowed a condition-warranted medication if they needed more drugs. So the example of a condition-warranted medication was beta blocker in coronary disease. It might be an alpha blocker in prostatic hypertrophy. And over half of the intensive group were on 3 or more medications. ACE/ARBs more than diuretics, diuretics more than calcium channel blockers more than beta blockers. And they followed people fairly closely. Monthly for the first 3 months to make sure they weren't having any side effects. Then it was every 3 months, and they drew blood tests on them every 3 months to make sure that there were no complications. But they were also assessing the progression of chronic kidney disease as one of the outcomes of the trial. So, mean blood pressure, 121 systolic mean blood pressure in the treated group, so they were able to get a very significant change in the degree of control of hypertension. But about 50% of the patients still were unable to reach their treatment goal. So, you could put people on 3 or maybe 4 medications and still not everybody's going to get there, and then I don't know about 5 or 6, But it does mean if you're in this cohort, this group of patients at high risk for cardiovascular disease without the exclusions, that, 3 to 4 medications should be something that we're thinking about. And they're all generic now, so they're pretty cheap. So what was the difference in the outcome? And remember, outcome's pretty short, a little over 3 years. So the primary outcome was a combination of whether someone had a myocardial infarction or acute coronary syndrome or a stroke or developed decompensated heart failure or died. And the number needed to treat is only 61. And for total mortality, you also had total mortality benefit. Average risk reduction 1.2%, number needed to treat 83. These are, really solid numbers. If I was talking about cancer screening before, it's like they would treat 300, 1,000, So, it's hard to argue with the benefit. It's a question of what it takes to get there. No real differences in the subgroups overall, pretty effective and everything. A couple ones I wanted to just show here. Here's the elderly, a little more effective if anything. If you're stratified by, starting at a lower blood pressure, that those patients were as affected, as benefited. There's no racial differences. There's no differences based on previous chronic kidney disease to speak of. And so I think you can apply it more broadly. Yes, there were some side effects. People had some episodes of hypertension with intensive treatment requiring people to back off. Small increased incidence in syncope or electrolyte abnormalities. Surprisingly enough, no difference in injurious falls. Sometimes people had a bump in their creatinine that you had to back off. But overall, these issues are all easily correctable with monitoring, and it just means that if you're going to put people through an intensive treatment protocol, that you got to be paying attention to them with a little more blood tests and maybe a little bit more email communication on what their levels are, and that they know if they feel lightheaded or if they get sick and they're feeling lightheaded, they need to do something a little bit differently. So one of the big controversies was looking at, okay, the Accord trial said no benefit in diabetics, and this trial excluded diabetics, so what do we do with the diabetics? And I'm just going to have you concentrate on this. This is from an editorial in New England Journal. This, to me, is the big thing here. So what does this show? This shows what the outcomes were, the event rates per standard treatment, and what the primary outcomes were in Sprint versus Accord. So this is the coronary event, and this is the stroke, and you don't see this blue thing here much in Accord because they didn't have acute uncompensated heart failure as one of their endpoints. So if you care about acute uncompensated heart failure as an endpoint, which I think we would, you kind of say, well, I don't know that I should exclude my diabetics. I don't think there's a basis to exclude the diabetics. I think it's a issue with how the trial was designed and an endpoint issue, and not necessarily a real difference that diabetics don't respond to lower blood pressure. That doesn't mean the harms might not also be a little bit greater. That's the great unknown, but it's an issue of needing to monitor people more closely. So my summary in the Sprint trial is that patients with or at high risk for cardiovascular disease benefit from more intensive blood pressure control. Adverse events are more common, but that means the tighter control is going to require more medication and more intense monitoring, and it really means that we have to have our teams well trained because doctors alone can't do all this.
How do we reconcile this with, these are the same people who a year ago who said, had an increase in mortality if you got their blood pressure below 150?
Yeah, so the question was, JNC8 cautioned us to increase the blood pressure target. So because this is the personalized approach to treatment of hypertension. So I got some slides that I think will shed some light on this, because we have to look at the patient in front of us and say, we're not all in a box, So before I get there, though, I want to give some guidance on when we have to think about the fourth drug, which should it be? Because, as I mentioned, diuretic, calcium channel blocker, ACE/ARB, those are the three. So this paper is from Lancet, and it's a randomized controlled trial that compared spironolactone versus placebo versus bisoprolol, which is a beta blocker, versus doxazosin in patients who had resistant hypertension. It's called the Pathway 2 trial. And it enrolled people between 18 and 79, and they had to have a seated blood pressure greater than 140. Diabetics, you could go down to 135. If they were using home blood pressure monitors, you could get 130, and they did home blood pressure monitor readings, 18 of them over 4 days. And they all had to be on maximally tolerated doses of those three main drugs. So they all had to be on maximally tolerated doses of ACE, calcium channel blocker, and diuretic. And they assessed adherence by actually measuring a home blood pressure 6 hours after somebody actually watched them take the medication, and they did pill counts and they did serum ACE because they really wanted to make sure the patients were adherent. So that's the inclusion criteria. They excluded patients with significant chronic kidney disease who might not be a candidate for spironolactone. And then what they did was they rotated each patient through 4 cycles of once daily treatment of spironolactone, bisoprolol, doxazosin. So the same patient got all 3 drugs. It's just that they were on spironolactone 25 for 6 weeks, and then at 6 weeks the dose was doubled to 50. And then when they were done with those 12 weeks, they went on bisoprolol 5 milligrams, and then they went up to 10. And then they stopped that and went to doxazosin and started them on 4 milligrams, and then after 6 weeks they doubled it to 8. Of course, whether it was tolerable for the patient or not. And there was no washout period, but because of the 12-week period, I don't think that's all that important. And then the primary endpoint was home blood pressure reading, and the results were really heavily in favor of spironolactone. So you got about an 8-millimeter reduction in blood pressure for the patients who had elevated hypertension, who were already on 3 drugs, who appeared to be adherent from adding spironolactone, whereas more like 4 millimeters for the rest. And so, highly significant for those patients who may need it. And so I think we ought to be thinking about spironolactone as our 4th drug. However, we've probably all seen this. When the K goes up to 6 over 6 and they're in the emergency room. And, so you got to watch people a little bit and check their blood tests pretty, we do this with heart failure because of the Ral's trial. You got to be on it, where you're checking it a few times here in the first few weeks, and then if you titrate the dose. So, an extra BMP is $10, so whether it's you're checking it weekly for 3 weeks or, weekly the first 2 weeks and then every other week for another few weeks, And in the trial, when they do that, the 2 incidents of hyperkalemia is 2%. But it's important to recognize, hey, it's new spironolactone. I better have a protocol in place, and I better be on this, and I better make sure the patient is on this and have the things that you need to monitor that. And then, the risk of gynecomastia for men, 6%. But highly significant reductions in blood pressure for patients that are at risk. So, Claudia, now I'm going to do, it's the pendulum. So now I'm on the aggressive hypertension trail, and now it's like, okay, there's some people we should not be doing this on. So this is a paper that was published in the fall in JAMA Internal Medicine out of the VA. It's a cohort study, over 200,000 folks, 70 and over who have diabetes, who are also treated for hypertension. And they stratified this patient population into 4 categories. Very low, which means tight control, systolic blood pressure less than a 120, or hemoglobin A1C less than 6. Moderately low, you can see there 120, 129, or a diastolic that's low. Hemoglobin A1C in the low 6s. Not low, systolic blood pressure greater than 130, or diastolic blood pressure greater than 65. Hemoglobin A1C greater than 65, and then high. So about half this cohort had a very or moderately low blood pressure. About 20% of them had a very low or moderately low hemoglobin A1C. And I think about 70 to 75% of them had a life expectancy less than 10 years. So, when you're making population-based recommendations and guidelines, you're also thinking about the harm. That's one of the key things about the USPTF. They really emphasize that. That's part of the, when you're making recommendations for aggressive treatment, maybe you're not thinking about the population-based approach and the thing for harm. So what did they notice? That de-intensification of therapy was uncommon. It was completely unrelated to whether the patient was going to have a limited or not, or very upbeat prognosis. And then if a patient had a very low blood pressure or hemoglobin A1C, it wasn't really looked at within 6 months because people say, hey, that looks pretty good. Instead of thinking, oh, this patient can barely walk down the hall and their blood pressure is 110, I better do something. And so, this is the importance of individualizing things. And it does appear that in this VA cohort that clinicians really didn't identify overtreatment as a potential risk. This kind of basically just tells you how often was de-intensification done. The dark bar is patients who had, life expectancy greater than 10 years. And the light bar is, less than 5 years. And, you're looking at in the low teens here. A little more common with glucose control, hemoglobin A1C less than 6. But, in these patients who have a life expectancy less than 5 years, where the guidelines would now suggest 8, 8.5, 27% of them had de-intensification of therapy. And so you can basically see, this pattern. And I think is one answer to your question is that we are doing harm here. And so there's a segment of the population who are older who may benefit. But this is the person who's still playing tennis who has a blood pressure that's treated for hypertension. Their blood pressure is 135, but it's not so many of the people that come into our clinics. This is a paper that I may have shown here last year, but it's on the same theme. This is a cohort study of nursing home residents age 80 and over, where they measured their blood pressure over 3 consecutive days, and they looked at their mortality based on their systolic blood pressure and whether or not they were receiving 2 or more antihypertensives. So, the best prognosis here is if you don't have hypertension and you don't need meds, that's better. If you do have hypertension and you're being treated with 2 or more drugs and your blood pressure is less than 130 and you're living in a nursing home, that's not so good. This is about the same. So it speaks to the de-intensification of therapy, making an appropriate target based on the individual patient. Along the same theme, these are patients who are elderly, who are cognitively impaired. Small cohort study, but same story. They had dementia or mild cognitive impairment, 9-month follow-up. Risk stratified the cohort into a low blood pressure of 128/90, more intermediate, high, looked at their mini mental status scores. If you intensively lowered their blood pressure, not so good. Not so good. With the lower blood pressures, not much difference up. So again, mild cognitive impairment, that lower blood pressure program, the SPRINT trial, you could be 75, but you could be high risk for coronary disease, but it probably doesn't apply to you. So on the other hand, if you're not treated with antihypertensive agents and you got a low blood pressure, well, you're not doing so bad. So having no low blood pressure versus, having hypertension versus not hypertension, you'd rather not have hypertension. Yeah.
Bob, do you know for some of these last couple of studies, for many of these patients, medicines that affect blood pressure are being used for cardiovascular comorbidities, heart failure, and the like.
It's coming. It's coming. Well, it's good. It means I got a good talk this year. It means the literature's there to help guide us. I threw the HIVET trial back in there again just because I am intentionally doing this pendulum. This is an old paper, New England Journal. Patients over 80 randomized to indapamide or placebo. These were low-risk patients over 80. And the target was 150 systolic, but low-risk patients, but very significant differences in stroke. I think this is heart failure. Big differences here in heart failure. I'm going to point this one out again. If I think about SPRINT versus ACCORD, they included heart failure. ACCORD did not include heart failure. I think preventing heart failure is kind of important. So
Very different than 121.
very different, but it doesn't mean that we don't treat old people. I think that very different. But over 25% of the SPRINT trial were patients over the age of 75, and they had if you looked at the subgroup analysis, as better, but within confidence intervals the same, but certainly not worse. So the conclusions on the hypertension piece is SPRINT trial indicates more aggressive blood pressure targets are warranted for some patients, including the elderly. These are patients that are high risk. We don't know about younger people because they didn't enroll people under the age of 50. We don't know about average risk people, but high risk people seems to be a reasonable thing to do. We ought to be thinking about those 3 drugs. If we have somebody who's hypertensive and they're not in control and they're not on 3 drugs, we got to know why that is. Have we really rock solid sure they're not taking their meds, because otherwise they need to be on more. And spironolactone is probably the best 4th drug in the absence of specific indication for another drug, and you can probably get control 90% of these patients. Personalized treatment goals are necessary where we need to be much more active about de-intensification for frail patients or those with adverse events. I have Steve Freer's voice in my head talking about clinical inertia. Remember that? He talks about clinical inertia. This is where, I think clinical inertia comes in play. And then, we're going to have systems in place with our teams to have that methodical, a reliable approach. I started spironolactone. I'm checking my blood tests this often. I'm checking in with my patient this often. If the blood test didn't come through, we're going to bird dog them so that they're not in the emergency room with a potassium of 6.5. So Laura, here's the paper you asked to see. This is a British Medical Journal. It was published in early October. It's a cohort study of almost 9,000 Medicare patients with at least 2 or more chronic conditions. And basically what they did was this was an in-home survey where they took a history from people about their clinical conditions, and they looked at their med cabinet. And they selected the conditions that had a 10% prevalence in the cohort or more. And that's how they ascertained whether someone was taking the medication, by actually looking at the container. So a pretty busy slide, but basically this is beta blockers, and these are the conditions. So if you have coronary disease and you have beta blockers, they're beneficial. This is statin. These are the single diseases. These are the combination of diseases. And by and large, if you have cardiovascular disease and diabetes and you're on a statin, it's beneficial. This is the calcium channel blocker one. It's beneficial. Thiazide's less so. Because maybe of the adverse events. But this is just in a population-based study. And then the ACE-ARBs, tend to be beneficial. So I think the issue about condition, people who are on guideline-based therapy for specific conditions says, by and large, for cardiovascular disease, use them. For cardiovascular disease, use them. Looking at some other stuff, this is clopidogrel Plavix, not a big difference. Looking at SSRIs, not a big difference. Warfarin, you got a specific indication like AFib or thromboembolic disease, big difference. If you have these other issues with multiple comorbidities, maybe less so. And then metformin, not as much of a difference as we might think for diabetic control, possibly because many of those patients that are on it don't have, could be de-intensified. So I think that my feeling there on this is guideline-based therapy is effective in the elderly, especially for cardiovascular drugs. Now, I included this paper on stroke and recurrent hemorrhage with patients who have AFib, because in the health plan, one of the things we noticed this year is that there was a 30% increase in stroke in our Medicare age population. And so we're pretty far along on this analysis, and you may start to find that you're going to get a list of patients who we're going to need to get some clinical data, because what the health plan has is claims data, diagnostic data, demographic data. We don't have clinical information. But what we're looking at is if the patients had a stroke, did they have a potentially modifiable risk factor before the stroke that maybe we could do a little better job on? So we were looking at, did they have a previous diagnosis of atrial fibrillation at least 3 months before their stroke? Did they have a diagnosis of hypertension before their stroke? Did they have hyperlipidemia before their stroke? And were they on 2 or more antihypertensives? Were they on a statin? Were they on an anticoagulant? It looks like about half the people who have a previous diagnosis of atrial fibrillation who had a stroke hadn't filled a prescription for an anticoagulant within 4 months of their stroke. There may be reasons for that. There may be reasons that are very appropriate for that. They may be non-adherent. We may not know. So part of the reason to get you engage the doctors is what can we learn about what we need to do differently. So I saw this paper also published this fall in BMJ. It's a Danish cohort study that looked at patients who had non-valvular AFib who had a GI bleed and looked at whether or not their GI bleed was restarted or not, and if so, what happened to their outcome. And over a quarter of the patients didn't resume any antithrombotic therapy. And basically what the results show is that if you didn't resume antithrombotic therapy, your mortality rate was, this is almost 20% higher than if you did. Not quite the same number of differences in looking at just thromboembolic events overall, but mortality rates were higher. And the risk was actually quite minimal, the risk of a GI bleed. It's much, much less than. So this was this single antithrombotic agent, which most of these were warfarin or an OX, relative risk reduction, 61%. So GI bleed alone shouldn't be a reason to exclude people. And we may be too cautious about excluding people because of the fear of falls. And we'll get more information about this. But that's why I put this paper in here.
Do you remember how quickly after the GI bleed? It was a couple weeks.
This study looked at people 30 days after the index event. They excluded the first 30 days. We're running a little short on time, so I'm going to go through this one pretty quickly. This has to do with the new PCSK9 inhibitors for hyperlipidemia. 2 of them are out there. I just showed one paper here. Over 4,000 patients who completed it. This is an open label trial. It's an injectable therapy. Costs over $14,000 a year. The known risk factors in the population were either known coronary disease, a quarter of them had family history, about 10% of them had familial hypercholesterolemia. 70% of them were on a statin, but out of those people on a statin, not that many of them were on a high-intensity statin. The median level of LDL coming in was 120, less than 120. And, they work, so they reduce your LDL by 61%. The trial is very premature. It's only a little bit over a year. Preventing an event, number need treat 81, but still, like I said, pretty premature. The ones that were predominantly prevented were a TIA or an episode of revascularization. But there's also a price to pay, this neurocognitive side effect that is probably about half the benefit that you're seeing. And this is 1 year, so we probably need a lot more time before we think about when we use these. The cost, like I said, almost $15,000. This is the incremental cost-effectiveness ratio based on current pricing, all which would be considered to be in the unacceptable range. They're going to need to reduce their cost by around half or more to get to, and then anything that anybody says is within the range of acceptability from a societal standpoint. And I wanted to show this other paper to feed your thinking here a little bit, because one of the reasons why people get excited about using these is because of the problems they have with statin intolerance. And the literature would show that the rate of statin intolerance is much less than what people think is in the clinical practice. So I thought this paper was kind of interesting. I basically was reading something to find a reference. I looked at this paper, and it had to do with vitamin D levels. And basically looked at patients who had musculoskeletal symptoms. They looked at their vitamin D levels. They started people on vitamin D supplementation if they needed to. 3 weeks after they repleted their vitamin D, they started them on a statin. For the purposes of this study, that was generally rosuvastatin, which is, by the way, going generic in about 6 months. And they did follow-up at 6, 12, and 24 months. And there was some significant dropout, but they don't know that dropout was from intolerance. But 90% of the patients were myalgia-free. So, how hard is it to actually say, okay, you're statin intolerant, let's check the vitamin D level. Pretty cheap to give vitamin D. It's not great evidence, but before I give somebody a $15,000 a year medication, let's check and replete vitamin D in these folks, and then re-challenge them with a statin and see how they do. That seems like something worth talking about.
You just give them the vitamin D, not check the level.
Well, these are people who are known to be depleted. I think that's a different thing. If you want to make the case that you should just treat everybody, and these are people who have a side effect of the medication, and then you investigate, and then they're known to be depleted. And people after they had myalgia after a statin say, "I'm never taking that again." Even if they have a cardiovascular event, and their risk for a future cardiovascular event is reduced by a third. So so we can do this. We can do this. I know we can do this. We're going to do this together. We're going to do this. Yeah. And then I'm going to close up on spinal stenosis. A couple of things I wanted to just point out here. One is a randomized controlled trial. This was kind of interesting. It's a small trial. They didn't have previous surgery. They were limited by their spinal stenosis to walking a quarter of a mile. But they were all surgical candidates, and they'd already consented to surgery. So these are people who are already willing to have surgery. They found 169 of these people who are willing to say, okay, I'll wait and get physical therapy for a 6-week course and then see what happens. And they had follow-up after 2 years, and their outcomes were, this survey tool, which basically looks at, their functional status, and they also completed these standardized tools that look at pain and functional status, the Oswestry Disability Index and the North American Spine Surgery Survey. High crossover, so what's the validity there? High crossover. Over half of them crossed over. 31 of those crossed over by week 10, because these were patients that already consented to surgery. 10 of those never had any PT. Average PT participation was over 8 visits, and 2/3 of the people in this cohort did attend at least 6 visits. And then people didn't really use other injections like therapies like injection. But the thing I thought was kind of interesting was, you're going to have some cohort here that is going to be able to be successful. So out of if you looked at the outcome at 2 years, the people who went to surgery right away, 61% had a successful outcome. The people that crossed over and waited, many of them would have waited, several months. And by the way, I should mention the average time that people had symptoms here was several months. I think it was 220 something days. So it's 8 months. But over half the patients who stuck with PT were able to get by without surgery. And so that means that maybe we could reduce the rate of surgical intervention on these folks by, 10, 15, 20%. So if people haven't tried PT, they could be told, you might avoid your surgery. If you decide to have surgery later, it will not affect your long-term outcome. And the outcome for you, if you're successful with physical therapy, is fairly equivalent to what it is for surgery. And so I think we have a potential to avoid some surgeries. And then, this is a systematic review looking at epidural corticosteroid injections. I included this because we now prior authorize those procedures in commercial. Medicare, actually, we started doing it in Medicare, and they had a change with the entity that looks at the evidence and makes recommendations and mandates things. So they didn't include any evidence from after 2013 when they mandated that you have to cover it. So we had to remove our Medicare prior authorization. But we're finding that 30% plus of the patients who are getting requests for epidurals don't meet any criteria that you could ever imagine. And the best way to avoid this is for doctors to use things that actually work. And so this is a systematic review looking at epidural steroids for radiculopathy, 8 of them compared to epidural steroids for spinal stenosis. They basically found that there was some modest immediate pain relief, but within 2 weeks, most of the people's pain relief went away. There was no meaningful improvement in function. There was a short-term delay in surgical rate from 2 weeks to 3 months, but there was really no delay in people getting surgery. So they got their injections and they got their surgery. And for spinal stenosis, there was no impact at all on pain and functional status. So spinal stenosis, many patients, I think, could avoid surgery and achieve similar functional outcomes if they go through a good trial of physical therapy and are willing to be patient. Those patients may avoid needless complications because about a third of the patients who got surgery had complications from those surgeries in terms of readmissions or infections or other things. Spinal injections, I think, are not that effective. And so if you're not going to have surgical therapy, really pushing people to being patient with their physical therapy is the way to go. And so we have some time for questions. Stunned silence.
So when would you ever approve epidural steroid injection?
Yeah, so they're approved for radiculopathy and disc herniation because of the issue about the short-term immediate relief. So we approve them. But I think if you did good shared decision-making, you'd kind of say, can you wait, can you wait, can you wait? Because if you can get through this, you won't have to have surgery. And if I do this injection, unless you got I have personal experience with this. And the evidence wasn't there. But I remember one of my injections was 2 days before I had to fly cross country. So there might be some personal circumstances. Stan.
Part of the narrative of the spinal, and I agree with you, I think it's ridiculous how many spinal injections we got. Having said that, there's a narrative. One narrative is, well, we can't be sure that it's this nerve root compression. So if we inject that nerve root and the pain goes away, that'll prove it, and then you can have surgery. So that's one of the little speeches that goes on. And it goes on and on like that. And the problem is, even if it takes away the pain, it's temporary. If there's an anatomical problem that's responsible for this, physical therapy may indeed change the anatomic relations in a way which is meaningful. And every patient, unless they're in just the most dire pain, should have physical therapy first. Because I think it's more than half the patients never need surgery.
Yeah.
And then pain clinics are pushing spinal injections. It's coming at you from all sides. And it just makes no sense.
So, thank you for validating me and not making me look like some wacko insurance company cheapskate.
Well, you may be that too. 'Cause that's
Any other questions? All right, thank you very much. Thanks for your attention.